I know that our first speaker, Andy, is just getting his slides loaded up. But while he's doing that, I might introduce him while he's got his back to you. There he is. So Andy, despite his very youthful looks, actually has over 20 years of experience working in mental health, and that's been through a variety of settings, inpatient, community. He's also done education work and management work. For the last 2.5 years, though, he's been the program manager with Living Well, Living Longer, which is Sydney Local Health District's program of integrated care aimed to improve the physical health of people with severe mental illness. He's also in the past and presented at the previous Equally Well conference on a side effect tool called the CEFS. CEFS, that's much easier to say, to increase conversations between consumers and clinicians about side effects and physical health. He was recently awarded a translational research grant to enhance mental health shared care with GPs, and that is around the topic that he's presenting on today. If everything's ready to go, Andy?
Okay, yes, so as Andrew said, I'm here to talk about the Living Well, Living Longer programme, which is Sydney Local Health District's integrated care programme aiming to improve the physical health of those living with severe mental illness. In particular, looking at an evaluation of the programme. When I commenced a couple of years ago, I was told this programme's been going for 5 years, we haven't really evaluated it. So that was one of the first tasks I set upon. So first of all, obviously, just to give the context, as you do at the start of the presentation, people are very familiar now, I think with the Equally Well consensus statement, so I'm not going to read it out. But when we look at, in particular, the life expectancy, this is the old, the way it tracked over the last century, this remarkable linear progression in life expectancy in Australia for men and women. Apparently, for every 10 years that goes by, you can be expected to live 2 years longer than someone that was born a decade before you. What we think, and there are a lot of assumptions and presumptions with this next line, but what we think's happened in the severe mental illness population may look a little bit more like this, with a fairly dramatic drop-off in the last 20 to 30 years, not coincidentally aligning with the introduction of second-generation antipsychotics, with the cardiometabolic side effects that they bring. Other literature took 20 years is actually quite a modest estimate. Some people say 25 to 30 years. And a key point is that the gap is actually, as far as we can gather, still widening. This isn't something that's yet been resolved. This is, I believe, a Scandinavian study which had another way of looking at it, which was average age of death for people over that 30-year period. You can see the darker red and blue lines at the back were the general population with that linear life progression, and the lighter red and blue lines are people with a diagnosis of schizophrenia in that country. Back in the 80s, pretty similar, especially for women, but you can see the dramatic drop-off over that time period. The reasons for this are invariably physical health related. The impact of suicide and self-harm is relatively small at only about less than 5%. So 2/3 of the causes of premature mortality are cardiovascular disease, respiratory disease, and cancer. That's defined as any death before the age of 70. This is the causes that they discovered. And in Australia, the National Mental Health Commission have called this situation a national disgrace. Of course, it's not just an Australian problem. This is a worldwide issue, and the World Health Organization have also published on this area. The key point that I've underlined here is that they talk about it being preventable physical health conditions that are leading to premature mortality, commonly overlooked not only by themselves and those around them, but also by health systems, which is sort of a fairly damning statement, really, from the World Health Organization on our ability to tackle this problem. That was back in 2012, I believe, they made that statement, which is really around the time that a lot of programs, just like my own, was starting to emerge. You know, the evidence of what takes a long time in health. I think I read once that it takes about 20 years for evidence to change into practice, and that's what we've seen really in with this problem. across the world, people started saying, oh, we better do something about this. So in Sydney Local Health District, it was in 2013 that we very first launched the Living Well, Living Longer program. And it was built around this idea of graduating people, I guess, through these 4 stages of screening, detection of physical health comorbidities, initiation of treatment, and into ongoing management for those conditions. Now, the way that we have done this is complex, and in my attempt to try and present a program of this size in one slide, I have put a lot of effort in and made a little bicycle tour for you. So, to start off with, on admission, so that's as soon as a care coordinator is allocated in our frontline mental health community services, we hope that physical health goals are set right from the outset. We have developed some physical health guidelines for our community mental health teams. We included in there a physical health discussion prompt tool. So that means that whoever you are as a care coordinator, no matter what your background is, even if you think you haven't got a clue about physical health, there are some very simple and basic questions you can ask. When did you last see your GP? Perhaps that's a good start. When did you last get a blood test done? And so on. So we've tried to help as much as we can. In that initial 28 days, we've got a statewide policy to conduct our metabolic screening, waist, weight, and blood pressure, and so on. But locally in our district, we ask care coordinators to set up a mental health shared care arrangement. So that's going along with the GP, with the person to visit their GP, introducing yourselves, and introducing a checklist that we have developed to set clear lines of accountability between the GP and mental health service. Then at some point during the first year, like ideally as soon as possible, we would like people to be referred to our cardiometabolic health clinic. It's called CC CHIP. I'll talk more about it in a second. Within CC CHIP, they'll see about 8 different specialists just to have a complete focus on their cardiometabolic health. That would include our lifestyle clinicians, so dietitians, exercise physiologists, smoking cessation. But care coordinators also have the option to refer directly to them, so you don't have to wait for a CC CHIP assessment to get a diet and exercise consult arranged. Similarly, within CC CHIP, they would see a dentist and receive free oral health check, and a free follow-up treatment would also be provided. And again, we've got an agreement with the oral health services locally that we can also directly refer. We don't have to wait for CC CHIP clinics to happen. We have an agreement that they will bypass the 2-year waiting list for free dental assessments and treatment in our district. We have funded and employed peer support workers who are integrated with some of our community mental health teams, and in particular there's 4 positions with a focus on health. I think all of our peer workers across the district, there may be 11 or 12, I think. Katie might correct me, but something like that. And all of them, of course, will hopefully have a focus on overall health and well-being, but these 4 in particular are called the health peer workers. They, as well as other things, will facilitate local groups and, pre-COVID, when permitted, but walking groups, yoga groups, whatever it may be, to try and improve and model good lifestyle behaviour. On a 6-monthly basis, care coordinators repeat that metabolic screening. By the way, we have a policy in our district that all of our care coordinators are trained to do metabolic screening. We have managed to get some psychologists to take waist measures. It's surprisingly challenging, but all of our care coordinators are trained and expected to complete that. And also the psychiatry review as a minimum. You'd expect a 6-monthly psychiatry review in our community mental health teams, where we hope side effects and physical health issues are also discussed. That brings us to this annual section. So the model is, I guess, built around an annual cycle. So people would be re-referred to CC CHIP every 12 months, where they can receive a follow-up assessment. And from there, a set of recommendations goes to the GP for action. And that doubles up as that kind of mental health shared care annual physical health check. So it sort of integrates nicely the shared care component with the cardiometabolic clinic that we offer. Last but not least, really crucially, I think a big part of what the program has done is, I guess, changing hearts and minds. I remember as a care coordinator around 11 or 12 years ago, I was told by my manager that I shouldn't be taking a person to see a dentist, that wasn't my job, that's not my problem, basically. Someone else needs to do that. And I think we've come a long way now to say, actually, this is all of our responsibility. We can't just presume that someone else is going to do this work, that we're not just focusing on mental health. So that's the program. The final gimmick for you, we know there are many barriers. So obviously, I think, to be perfectly honest, probably a small minority of our community receive every single intervention in that very perfect manner. But we try our best. That's our gold standard, and this is what we set out to achieve in our district. So a little bit more about, I guess, our three main components would be our cardiometabolic health clinics, the Collaborative Centre for Cardiometabolic Health in Psychosis. So individuals are referred by their care coordinators or some direct referrals from GPs as well. They would go along for an afternoon, spend about 2 hours in this clinic where they would see 8 or 9 different specialists, including staff specialists, cardiologists, endocrinologists. That a full blood workup would be done in advance so that a thorough, comprehensive assessment can be made. I believe the clinic boasts that they collect 2,000 columns of data for every individual that they see. It's a huge kind of undertaking. And you can see the image here is the different clinicians meeting up at the end of the clinic where they all discuss the presentations that they saw and formulate a set of recommendations. It is remarkable how every week they discover someone who they suspect has probably had untreated diabetes for 10 years. Literally, it's a weekly occurrence. So it's gone a long way to improving our screening and detection and treatment rates in our district. This is some of the numbers. So up until the pandemic, now obviously CC chip numbers have halved over the last 2 years, unfortunately, because many clinics have been closed. They've had to reduce numbers for social distancing reasons and so on, so it's been a challenge. But up until the pandemic, you could see there'd been around 1,800 appointments altogether. The blue section is those first visits, so that's unique individuals. Over 1,000 different community mental health consumers had been through CC chip in that period. Second big component is our mental health shared care program. So as I mentioned, we provide a checklist which assigns tasks to a GP and a care coordinator. And really importantly, it's about improving communication. Care coordinators will always complain about a lack of information from GPs. I've been doing this job and spoken to enough GPs now that I'm aware that all of the GPs think that communication from mental health services is also terrible. So it's a two-way street, and we are trying to address this and really improve those relationships. It's based on an annual cycle, and we have appointed a couple of CNC positions to support the model. We've got 2 sectors in our district, East and West, and there's a sector-based CNC that pushes the model forward with the teams in each sector. Here's our checklist, obviously very wordy, but just to give you an idea, the light blue section is the tasks that are assigned to the GP. That includes, an annual physical health check, effectively, in prescribing of any physical health medications. And the darker blue section is those tasks for the mental health service. So we'll make sure those bloods are ordered in advance of the appointment, so when the person arrives, the GP's got something straight away ready to review. We'll arrange any CC chip referrals, and we'll take responsibility for the mental health medications. In terms of numbers, we're quite proud of the number of people we've engaged in shared care. This is a sort of based on a monthly snapshots of the number of active people in shared care. You can see the purple line. We've got around 700 or so people in our district engaged in shared care at any one time. It's around 1/3 of all of our mental health consumers. The orange line shows you the number of GPs. Around 300 different GPs in the district are involved. And the green line is those annual physical health checks as they're occurring. You can see the impact of Delta and Omicron, the way the lines have all sloped off a little bit in the last 9 months. So that's obviously a challenge, but we're hoping this year to drive it forwards. And I'll mention at the end, we've actually just engaged, I think Andrew said in the introduction, we've just engaged in a trial to introduce web-based care plans, so we can actually have a direct online communication platform between GPs and mental health care coordinators, which we hope will really bump up the model as well and improve the care that people receive. Finally, we employ lifestyle clinicians. They work with consumers to develop individualized, achievable, and relevant health behavior change goals and support the practical strategies required to achieve those goals. So we have a KPI that any referral from a care coordinator will be actioned, and a consult will be arranged within 2 weeks, and we're pretty on track with achieving that. So it is by referral basis. We think that works pretty well because it means that generally the people who are referred are saying, you know, yeah, okay, I'd like to have a look at that. They're ready to consider change in their lifestyle. The district-wide positions, so they offer joint consults and combined diet and exercise consults or individual ones. They're integrated with CC CHIP, so the same clinicians that cover the community also do that kind of 10-minute assessment within our cardiometabolic clinic. So that's very handy because they can offer follow-up while they're at our CC CHIP clinics. And when COVID allows, they do offer groups as well. We've got the 12-week Healthy Lifestyle Group program, and we have partnered with a local aquatic centre in Sydney to offer a gym and swim group, which has been hugely popular and successful. I believe my colleague is presenting on that shortly as well in another room. But we've seen huge numbers and very sort of a real collaborative sense of people coming together for this group, and we've upskilled people to feel confident to go to the gym independently, and we've had many members become members and attend independently, which is, I guess, is the whole goal. So in terms of our districts, I can just tell you a little bit about our consumers. There's around just over 2,000 in our community mental health services, mostly in our adult community teams, but we do have specialist teams as well. Around 57% are male, normal curve on the age distribution with an average age of around 41. Just over half have a diagnosis of schizophrenia. And in terms of length of stay, it's an interesting point that only 48% of our consumers actually have a length of stay for over 2 years. There's quite a 10% discharge and admission rate every month, a kind of relatively constant turnover. So that's the first challenge when it comes to evaluating a program that's been going for 5 or 6 years. And then also relatively, I would suggest relatively high levels of involuntary treatment. Around 23% of everybody is on a community treatment order. So when we evaluated our program, the first thing we did was to look at getting consumer feedback. A poster was designed by one of our peer workers. We invited people to come to a barbecue. Our dietitians did our best to prove that barbecues could be delicious and still healthy. And we had about 25 consumers attend, and they gave us some feedback about what's going well. It was really pleasing that they mentioned all of the different components of the program in some form. And when we asked how we could improve, they all said they wanted more groups and more chance to come together. So we did from that develop a database of all the different kind of health groups that go on across the district and share that and encourage more groups to be commenced. The other thing we do is the dreaded annual physical health audit. The care coordinators adore, but we ask everyone to provide a full sort of set of data, engagement with physical health over their entire sort of care load. Now you can see that when we first did the audit back in February 2015, only 62% even had a named GP. We've managed to get that up to 88%. We've doubled our rates of physical health checks, but the most shocking is that third column there. Back in the day, we only found evidence of any communication with the GP in 2% of patient files. We've now got that up, and that was in the preceding 6 months. We've now got that up to just over 50%. Obviously, we'd love it to be 100%, so still some way to go. Now, in terms of evaluating health outcomes, this program was always set up as a clinical program. It was never set up as research. So, we didn't have particularly, ethics-approved evidence sort of right from the outset. But fortunately, our dietitians and exercise physiologists very early on did do a sort of needs analysis for our community. And they looked at some various measures on a power-calculated sample of 251 consumers. And this is what they found. Now, some pretty shocking measures when you consider the Australian averages. The waist is about 15 centimetres higher than the average Australian, and weight 10 kilos above, and BMI also quite a bit higher into that early obese range. Bearing in mind the Australian average there is bang in the middle of the overweight obese range. Oh, I'm going to have to speed up a little bit. Okay, so quickly, the way we have then, during the COVID period, we had some dietitian students come and they repeated this. They looked at that 251 and they found that 108 of them were still linked to the service. Unfortunately, well, not unfortunately, but just by the nature of them being our more long-term consumers, they tended to have quite high rates of metabolic syndrome. Basically, a lot of them were our clozapine consumers who have been engaged in the service for a long time. But we thought, well, let's have a look anyway and see what's happened to those 108. Interestingly, very little change in average waist or weight, but we did find some improvements, a small but statistically significant improvement in blood pressure and also some improvements in lipid profile, which was quite a bit of a surprise, not what we were necessarily expecting. Finally, there's sort of a future group of students also during a COVID period a bit later that year thought, well, let's resample up to another 251, and I won't go into this, but they made sure that the group was proportionate to the number of people who were prescribed clozapine as well, just because of the increased metabolic risks for that group. What you need to know is it's a comparison of 251 from 2016 and from 2020, and we found it's an apparent 4 centimetre reduction in average waist, although it didn't have statistical significance, so as I was told by Professor Lambert, must be interpreted as no change, which was slightly disappointing. But equally, we did find again some improvements in lipids, improvement in blood sugars, and also in BMI back into the, back into that overweight range at 29 with statistical significance. Now, I should acknowledge that comparing to snapshots like this is really poor scientific method. It doesn't have any real rigor. But nevertheless, it was interesting and eye-opening that perhaps we might have expected things to be getting worse, and maybe it's not. Maybe there's more going on. We've currently got a huge sort of multivariate analysis underway with over 12,000 metabolic modules across our district over the last 6 or 7 years to try and validate what we've been finding, that maybe we've at least slowed, but maybe even improved slightly some of the metabolic measures through what we've done. I think I'm slightly over time, so maybe I won't have time to read through all of these, but you could have a look and ask me any questions afterwards. These are some of the future directions that are going on at the moment, and I think that's going to be just about it. So thank you for listening.